Today we will be discussing on MME 102 and MMEL 102, that is related to obstetrics and gynecology of PGDMC's program. To discuss the issues, we have three experts today. To my right, Professor Sunesh Kumar. He is professor at All India Institute of Medical Sciences. He has been involved in our program as a course writer and also editor. To his right, Professor Chitra Raghunandan. She is professor at Lady Hardinge Medical College. She is also involved as a course writer and editor, and also has been involved as a counselor for the PGDMC students for last 5-7 years. And to the extreme right, Professor Gauri Gandhi. She is professor at Maulana Azam Medical College and also has been involved as a counselor. In this session, we will discuss details about partogram.
Whenever the patient comes with term pregnancy and pain in abdomen, we have to diagnose that they are in true labor. The true labor pains are associated with hardening of the uterus. They are associated with relaxation in between and coming contractions and pain in repeated interval, and which gradually progress in intensity, duration, intervals between the pains shorten. So this must be inquired on a history. A thorough history and examination is important at the time of admission of the patient in labor. You should also ask the history of any discharge per vaginum, which may be blood mixed mucus, leaking or even bleeding PV. Then we must subject this patient to a thorough examination after screening through our antenatal record if she has got one, which will also tell us that she has passed through her pregnancy normally. If there is any abnormality of pregnancy, high risk situation in pregnancy is detected now after a second screening through the antenatal record, you still have the time now for this high risk patient, like a patient now who has developed high blood pressure in last weeks of pregnancy and has come to you in labor only, patient who gives history of some bleeding per vaginum. Now these are the high risk patients whom you can detect even in the early stages of labor and timely refer this patient for a higher center for delivery. You should also pick up those cases who are preterm labor. Maybe she was not sure about her dates and she has gone into preterm labor, because this again is an emergency situation when we don't want a preterm low birth weight baby to be born, and so we must suppress labor if there is a preterm labor. So we have to exclude at the time of admission preterm labor and certain high risk pregnancies which can come into detection at this time. After ensuring that the patient is in case of a normal term pregnancy, has a normal longitudinal lie, baby size is average, the fetal heart sounds are normal on clinical examination, you keep this patient with yourself to monitor her labor and conduct her delivery. The basic preliminary investigation you would do at this time is to check her hemoglobin if it has not been done in the last few weeks of pregnancy. Check her urine for albumin and sugar, and if she has been in labor for a long time, then even acetone in the urine should be checked. Blood group, if not already known, can be done at this time, and a blood group and should be also known before the onset of before conducting delivery. Monitor the first stage, that is from the onset of labor pains till the full cervical dilatation. Monitor her during the second stage of labor, that is from full cervical dilatation to the delivery of the baby. Monitor during the third stage of labor, that is after the delivery of the baby, the delivery of the placenta and membrane, and complete retraction of the uterus, so that the blood loss is within normal limits. There is no postpartum hemorrhage in the third stage of labor.
Can you tell us what are the parts of the partograph and how the students will actually plot and take decisions from time to time?
In the monitoring of the first stage of labor, as we take up now, the partograph is the most important component of the monitoring of the first stage of labor. If you see a partograph, the top portion has the record of patient's name, registration number, age, the date of admission, the time of admission, and after that there is a fetal component. The fetal heart sounds are recorded every half hourly. The segments that are there in the partogram are divided by hours, 0 hour, 1 hour, 2 hour, 3 hour, like that till 24 hours. In the upper part of the graph you see each hour is also divided into half hour squares. So these are, so the fetal heart sound is on the top of the list, followed by Leica and then the molding. So these three records will be the record of the baby. The fetal heart sounds are recorded. They are, the numbers are between 120 to 180. So the records will be made every half hourly during the first stage of labor. So that is the fetal heart. If there is a meconium in the Leica is present, it is recorded as M. If it is a clear Leica, it is recorded as C. If the molding is absent, it is recorded as A. If there is nil, or if there is a molding 1 plus 2 plus, this is the way the molding is recorded. Then comes the main component of the partograph, that is the cervical dilatation. The graph shows a straight line from 0 to 8 hours, that is the latent phase. From 8 hours till another 6 hours, that is up to 14 hours, there is an action line, that is this corresponds to the 1 centimeter per hour dilatation of the cervix from 8 centimeter onwards. On to the right side of this alert line there is an action line which is 4 hours later. So that is an action line which is another dark line that you can see. Now if you have below this, you have the record of intravenous fluids administered to the patient, any drugs administered to the patient, and in between them there is a record for the monitoring the uterine contractions. So uterine contractions, you have 5 segments in that uterine contractions. Uterine contractions, the number of contractions which are occurring within 10 minutes is recorded one above another. Suppose there are 2 contractions, you will darken 2 segments in that 5 segments from below upwards. So every half hourly the uterine contractions will also be marked. If the contractions are lasting for about 20 to 40 seconds, you can give them a separate color. If they last between 40 to 60 seconds, you give them another color, and more stronger contractions beyond that will be darkened further. So the intensity of contractions can also be put on the graph, and from that you will know at what phase the contractions are going on increasing. If the patient comes in the latent phase, that is at the time of admission, when you examine the patient, you do a pervaginal examination to know the cervical effacement, dilatation, distension and position of the head, the membranes whether they are present, and then the adequacy of the pelvis. At that time you have noted down whether the cervix is dilated up to 3 centimeter only, that is she is in the latent phase. So now you mark the time of admission in that graph at 0.0 hours, and then you note down the dilatation of the cervix at this time on the latent phase line. If she is coming after 4 centimeters of dilatation, that is at the admission, you find that she is in active phase. Now this graphic recording should be done on the alert line. The first patient has come at 4 centimeter dilatation, so you have noted down the time below that, and the patient as the partograph you have marked on the alert.
Dr. Sundas, will you like to
acute diarrhea I had mentioned in that.
Yeah. So we have seen in great majority by simple measures like plenty of fluids, oral rehydration solution, these infections get controlled. They are self-limiting. Only if she is very sick, she is having lot of blood in the stool, she is getting dehydrated, in that situation we will have to institute specific treatment. Like for amoebiasis, we will have to think of giving metronidazole.
If the patient is coming in the active phase, then that is after 4 centimeter dilatation and above, the record is made directly on the action line. But if she is coming in the latent phase, that is before 4 centimeter dilatation, the record is made in the latent phase part of the graph. Now the PV examination is repeated to know the cervical dilatation after every 4 hours. So you will be recording the progress of cervical dilatation in the latent phase and in the action alert line, with dilatation marked on the left side of the graph. You know that there is 1 centimeter, 2 centimeter, like that is put up to 10 centimeter. So according to the dilatation, you will mark with the centimeters the dilatation that she has got. You will mark it on the action alert line once she is in active phase. Then the next PV examination you do after 4 hours, or maybe earlier if she delivers early. So the next PV record will show the progress in the cervical dilatation, and that will also be marked on the alert line. Now the patient has come in the latent phase. She is 1 centimeter dilated at admission. So here you are marking in the latent phase of the graph. Now the next PV examination which has been done after 4 hours of admission, the dilatation has become 6 centimeter. Now the 6 centimeter, now it should be transferred onto the alert line. Now 6 centimeter transfer is written, and it is transferred onto the alert line. The next dilatation after 4 hours is 10 centimeter. So there is another mark after 4 hours on the graph which is 10 centimeter according to the centimeters marked onto the left side of the graph. So if you add these, you will find that the graph is well within the alert line, that is onto the left side of the alert line, and the patient's progress is normal. So the basic principle is, if the patient comes in latent phase, you mark the graph onto the latent phase. If she comes onto the active phase after 4 centimeter dilatation, then you mark the graphs on beginning on the alert line. And if within 8 hours she becomes active 4 centimeter and above dilated, you have to transfer the markings from the latent phase of the graph to the alert line. So that is what is the graphic recording of the progress of labor. Here is the descent of the head is also to be marked on this graph. So we record this descent as 5th above brim, 4/5 above brim, 3/5, 2/5, 1/5, as the head enters from the pelvic brim into the cavity and to the 0 level, that is at the level of ischial spines, when the no part of the head will be palpable per abdomen. So here is WHO tells you how to record this 5th above brim. So if you put 5 fingers above over the fetal head, and that means it is all above the brim. If you are able to put 4 fingers above the head, which is palpable per abdomen, it is 4/5 above brim. Here the last picture is 2 fingers have been put over the head, 2 fingers above the brim. Now the descent of the head is now again marked through 0 to 5 on to the left side of this graph. Now the patient comes with at admission, she is free at brim, that is 5th above brim. So that has been marked on the graph as regards this. Now after 4 hours, the descent has just become 4/5 above brim. So it has the head has not entered very well into the pelvis, so it is still 4/5 above brim after 4 hours. So that has again been marked onto the descent, the dark line which is marking the descent of the head. Now suddenly after this thing, she is dilated about 5 centimeter. So the graph is getting transferred from the latent phase portion onto the alert line. So 6 centimeter has been marked on the alert line. Now after that, the next PV examination after about 3 hours is showing 10 centimeter dilatation. So that cervix is now fully dilated, and the head has descended from 4/5 above brim, and it has come down to the 0 level. No pole is palpable, that is, it is almost they're getting delivered out. So descent of the head and cervical dilatation both have been marked in this partograph. Here the lower portion is showing the uterine contractions. Initially the lightly marked contraction 2 per 10 minutes, 2 and 3 per minutes, moderate contractions. So they have been colored differently. Initial one is light, later one, the middle one is shaded, and the last strong contractions, almost 5 contractions, every 2 minutes contractions have been coming. So 5 segments have been colored in this part. So they are strong contraction which are now corresponding to full cervical dilatation and delivery of the head. So this is again a composite graph which is showing dilatation as well as descent of the head. On the top you are recording the fetal heart sound ranging between 120 to 140. So the transfer of the graph was done from 5 centimeter to the alert line. So there you don't find any graphic record of the fetal heart. Again, after 4 centimeter graphic record of the fetal heart is being marked. In between there is a contraction is also being marked. Initially slow contractions, less contractions, later on strong contraction lasting more than 40 seconds per minute and also coming very frequently. So the entire thing is being darkened out, so they suggest strong contractions. Descent of the head as has been marked 5 centimeter, fifth above brim, almost free at brim, and after that it is coming to 4 fifth above brim, and after full cervical dilatation it has come down to 0. But this dilatation descent of the head has somewhat been slower, but the baby has delivered with strong contractions. Now here the labor curve is going on to the right side of the alert line. Dilatation at 3 centimeter, 4 centimeter, then 6 centimeter after 4 hours and 7 centimeter for another 4 hours. So when they have been marked on the graph, they are falling on to the right side of the alert line, that is in between alert line and action line. So there has been some delay. So what is this delay? The delay is either because there is delay, the uterine contractions have slowed down, pelvis is adequate, or even then the slow progress may be due to minor cephalopelvic disproportion, minor malposition of the head which has delayed, but with some intervention, probably with oxytocin, the labor dilatation as now may have, there is a delay now, there is a progress, it has been arrested at 6 centimeter dilatation. Even the descent of the head starting at 4 fifth above brim has come down to 3, but the descent has not occurred. So both these have now are crossing onto the alert line, from alert line to action line. So this is the graph which shows that there has been a slow progress of cervical dilatation, slow progress of the descent of the head. So this is the graph which now tells you that the patient should be sent to a referral unit for further assessment for cephalopelvic disproportion or poor uterine contractions, and an intervention must be carried out. So this is the time that you have to refer the patient fast to first referral unit. Now here again, this is the shaded portion between alert line and action line, delay in labor. So these are the patients who would require intervention at a higher center. So if the graph goes beyond alert line onto the right side, refer the patient immediately for further intervention if you cannot manage this patient at your place. One thing I would like to say, that assessment of the fetal head should mainly be done per abdomen, and for hourly PV you are doing vaginally also, you are assessing the descent of the head, but it is first you have to do an abdominal examination for the descent of the head, and if you feel that you are more comfortable, if you cannot find out exactly the descent is satisfactory, you have to combine with per vaginal examination.
Is it necessary to maintain partogram, Dr. Sunesh?
See, we all know that great majority of labors are being monitored either at home or at small hospital, mostly by nurses, lady health visitor. So what authorities and what WHO thought, we need to have a system where people who are managing labor are able to pick abnormalities well in time, and they are able to refer patient well in time. So by use of partogram, we are able to pick up abnormalities of labor well in time and refer the patient so that she reaches a center where if operation is needed can be done. And this has been a big advantage. Wherever partogram has been used, it has been shown that they are able to reduce maternal morbidity and mortality.
If you want to reduce maternal mortality and morbidity as a result of prolonged labor, partograph is the tool from which you can pick up. It just serves as a screening for abnormal labors which are getting prolonged. You can pick them up through the partograph and then refer them in time so that the mother and baby can be saved, which is the ultimate aim of the entire teaching program.